So in the previous lesson, we talked about sinus tachycardia, how the sinus tachycardia manifests in the ECG, and we also talked about what actually you mean by sinus tachycardia, which is appropriate. So now we're gonna go on to the topic which is called as pathological sinus tachycardia. If you've not already seen sinus tachycardia, please watch this and then come back to this. So what are the three types of pathological sinus tachycardia? First is inappropriate sinus tachycardia, POTS, which is postural orthostatic tachycardia syndrome. Then we have sinoatrial reentrant tachycardia. We're going to discuss each one of them in detail and let's just understand to its core. First in the list is inappropriate sinus tachycardia. So when we call about what exactly is appropriate sinus tachycardia is when there is an identifiable cause, and inappropriate sinus tachycardia when there's apparently no cause which is found. For example, in cases of fever, as you know, for every 1 degree, there's a rise in pulse by almost 10 beats per minute. Such is called as appropriate sinus tachycardia. But when there's absolutely no cause that is found and the patient is still having symptoms, it's called as inappropriate sinus tachycardia. So, first and the foremost, there should not be any reason missed for inappropriate sinus tachycardia terminology. For some reasons, the epidemiology goes like it's most common in females who are in their 30s. Most tachycardias are common in females, and for some unknown reason, it's more common in healthcare workers. I think it's something has to do with maybe some resting stress, resting work stress or something, and there's enhanced automaticity that has been found in SNO when there's inappropriate sinus tachycardia. So it's very crucial to rule out the causes of appropriate sinus tachycardia so that we can treat this accordingly. Okay, so we're down with inappropriate sinus tachycardia. Let's understand what is POTS or postural orthostatic tachycardia syndrome. So what is POTS is when the patient stands for about let's say 3 minutes. 3 minutes later, he experiences fast heartbeat, and which is tachycardia on standing. But when the patient lies flat or is recumbent in position, the tachycardia actually disappears. That is what the basic mechanism of POTS is. So, coming to the actual figures, if you're doing the tilt table test, it's one of the tests that we usually do for patients who are experiencing pre-syncope, giddiness, or syncope like a picture that rules out orthostatic hypertension or even POTS. So when you actually do tilt table test, you have more than or equal to 30 beats increase from the baseline, from the absolute heart rate of the patient, or absolute heart rate of more than 120, but there's hardly any change in the blood pressure of the patient. So for the figures, BP should not rise by more than 30 in systolic and should not be more than 20 in mean atrial pressure on 3 minutes of standing or by tilt table test. So this is how we confirm whether the patient has POTS or not. And tilt table test is absolute. You can also carry on some bedside test where you make the patient flat and then tell them to just stand for 3 minutes, check if there's any tachycardia or something. So the cause for the POTS is usually multifactorial. There is hardly a peculiar cause that's pinpointed, but it has been observed that there is antecedent viral infection that has been noticed in couple of patients. So in the actual body, what happens is one of the cause being post-ganglionic sympathetic denervation in legs. So if the legs muscles do not have sympathetic ganglionic denervation, the vessels in the legs lose their vasomotor tone and there occurs venous pulling of blood in the legs. That results in decreased blood supply to the heart, which eventually results into sinus stimulation, and that's gonna cause the tachycardia. So post-ganglionic sympathetic denervation that could be due to viral cause, as we mentioned, is one of the cause for your POTS. Similarly, if there is a splanchnic pooling of volume of blood or a fluid, that can also result in POTS-like picture. If there is hypovolemia, that can give you a similar picture like POTS. So it's not just this SN node. In POTS, you can have all these other causes which can also result in a similar condition like POTS. So if there's a disease in the SN node itself, we can treat it with let's say antiarrhythmics or SN nodal radiofrequency ablation. But if there's the cause is secondary, as in this case like hypovolemia or this one, it's very difficult to treat such causes. As I mentioned, patient may have sinus nodal abnormality itself, and if that is the cause, which is treatable, easily treatable, and other causes, you need to take extra care to find out and to treat as well. Coming to the last topic for our topic, which is pathological sinus tachycardia, we're gonna ended up with sinoatrial reentrant, or acronymed as SART, which stands for sinoatrial reentrant tachycardia. As the name itself suggests, it's a reentrant tachycardia. And I've drawn a little pictorial diagram where you can see this is a micro reentrant circuit. So it's a micro reentrant tachycardia because the circuit is not involving ventricles or other atrium. So it's only restricted to one atria, and usually the site is SN node at the adjacent RA myocardium. Okay, so it's also micro reentrant tachycardia involving the sinus node. What happens in SART and why is it so difficult to differentiate from your normal sinus tachycardia is the morphology. So since the SN node is part of the reentrant circuit, it exactly looks similar to your sinus tachycardia. It's just that the PAC, which is your premature atrial complex, can actually precipitate this tachycardia, and it also gets terminated if there's PAC. So this is one of those tachycardias which is paroxysmal in nature. The thing with your sinus tachycardia, it rises slowly and also decelerates slowly. So it's non-paroxysmal. But this one is paroxysmal. It's precipitated and most oftenly is also terminated by your PAC. Coming to the next point, so since it's a form of SVT, of course, it's gonna respond to your carotid body stimulation, vagal maneuvers, and also to the AV nodal blocking agents like your beta blockers and calcium channel blockers. So it can be blocked by vagal maneuvers and AV nodal blocking agents. The usual heart rate for the SART is between 100 to 150 beats per minute, and it's usually can be also less than 100 for the SART, and that is very difficult to differentiate when it's less than 100. So let's understand the mechanism. As I mentioned in the diagram, it's a micro reentrant circuit which is involving your SN node. So when the SN node is involved, the picture is going to look similar to the sinus tachycardia. The P wave is going to be upright in all the frontal and also the precordial leads, and the heart rate, as I mentioned, it's going to be 120 to 150 beats per minute. So whenever there is SART, you patient are less likely to be symptomatic because the heart rate is not pushing more than 150. So it's one of the rarest of the tachycard SVTs, and it occurs in less than 5% of the re-entrant SVTs. That is one of the most important clinical implication. And what we need to know about SART is it's most commonly associated with some form of structural heart disease, which is involving with the location, that is the SN node and the re-entrant myocardium. So what exactly are you going to do to suspect or even confirm the diagnosis is this paroxysmal nature? That is the only way where we can, even think of SART. And of course, like your AV nodal blocking agents and your carotid massage, you can also go for radiofrequency ablation as the definitive treatment whenever you have the confirmed SART present. So, so far so good. We have covered all the three forms of pathological sinus tachycardia, which is inappropriate sinus tachycardia, POTS, and also the last one, which is your SART. So they are going to look exactly similar to your sinus tachycardia. It's just the cause, the morphology, Morphology is going to be the same. It's just that the cause differs, and also the patient profile is going to differ a little bit. A quick fitness step is whenever you are doing some form of resistance training, I suggest you not to focus on the concentric motion but also on the eccentric motion. What I mean by this is, let's just say you are training bicep curls. So for bicep curls, this is going to be against the gravity, and this is also against the gravity. So your biceps are gonna get fully contracted in this motion, but they're gonna get stretched when you are going against the gravity. So the eccentric part of movement is when your muscle is actually going to grow. So focus on the eccentric part of movement as well. Slow and steady wins the race. If you haven't already watched Sinus Tachycardia, go and watch it. Give me thumbs up, like, share, and subscribe.